Ma'am, please unmute.
Hello, ma'am. Hello, ma'am. Hello, Pavan. Am I audible?
Ji, ma'am, you are audible.
Okay. So, good evening, everyone. So, and welcome to day 4 of the DHR HRD course. And so today we have as speaker Professor Veena Jain ma'am from AIMS New Delhi Department of Prosthodontics. And ma'am has been an eminent prosthodontist, eminent researcher in the field of prosthodontics. And she has been a core heart academician and clinician. So I welcome you, ma'am, and it's over to you to start the presentation. If you would like to share your screen also. Can we help you, ma'am?
Greeting to all the delegates from New Delhi.
Yes,
I
ma'am.
myself is Dr. Veena Jain from All India Institute of Medical Sciences, New Delhi. And before starting my presentation, I want to acknowledge the organizing committee of 6th International Craniofacial and Dental Summit for giving me this opportunity. This is our institute where I'm working, and this is our center, our dental center, where we are doing our routine daily work. And today I will discuss about the application of facial scanners in the rehabilitation of the facial defects. So why face is so important to us? We know because the face is the most prominent part in our body. And if we see in the ancient time, we go long back, people use different type of the beautiful faces not just to hide their identity or to change, or rather we can say to change their identity or look different. So why it is so? Because face give us identity. And what is our state of mind that is also expressed on our face, because on the face there are different muscles are there to express our emotions. So even minor deviation in the facial anatomy lead to the impact on the psychological status, so that further affect the self-confidence, esteem, and the social behavior of any individuals. Sometimes these defects are associated with oral cavity. In that cases, even the function of the oral cavity like mastication, speech, and deglutition is affected. And sometimes defect is so large person feel handicapped. And even in some cases, they feel we cannot rehabilitate it. So the suicidal tendency, person has developed the suicidal tendency. If we go into the history or see the back on the back of our the back of the how to the in the past the prostheses were fabricated, the sign of early facial, even the facial prosthesis or limb prosthesis found in Egyptian or Iranian mummies in 3000 BC. At that time, these prostheses were made of wood, metal, bitumen paste, which was covered with gold. Since then, till now, there is lot of advancement in material science as well as the technology, especially with the introduction of the 3D technology, which was initially introduced in the automobile industry, or we can say in aeroplane or the aerodynamics. And later on, the same technology was used for the fabrication of the limb prosthesis, and now today we are using it for the fabrication of the facial prosthesis as well. So facial scanners are the latest advancement in this 3D technology. And with the advent of 3D technology and the further introduction of the facial scanner, they have simplified the fabrication of the prosthesis. So it's very important for us for the effective use of this technology as well as the facial scanner. When we must understand we have to use them, where we can use them, and how to integrate these technology with the existing technologies. So the main purpose of this presentation is to make out or to explain we can use this technology effectively, where we can use it, and what advantage we can gain with the use of these technologies. So for the rehabilitation of the defect, whether we are rehabilitating with the conventional method or we are going to use the 3D method, some steps are remain always same. Whenever patient reported to us, we must examine the defect. When examining the defect, first of all, we must know how the defect is created, what is the etiology. So most of the time, these defects in our institute, especially, most of the patients are reported due to the acquired defect. And in the acquired, most common cause is the cancer, and the second most common reason for the patient reported is the congenital defects. So for the rehabilitation of these defects, we have mainly two options with the surgical reconstruction and the prosthetic reconstruction. Under the surgical reconstruction, we know it's not possible each and every case because surgical reconstruction depends on the site and the size of the tumor. Beside that, we have to see the subtle or intricate characteristic of the underlying tissue as well as the surrounding structures. If there is chances for the recurrence of the tumor or the underlying tissues are not healthy or fibrous and defect is large, surgical reconstruction is not possible. In those cases, anyway, we have to go for the maxillofacial rehabilitation. But in the prosthetic rehabilitation, before the introduction of introduction of the 3D technologies, there are a number of steps for the rehabilitation of these defects. So entire procedure required number of steps. So this procedure is labor intensive as well as the time consuming and the final result secondary to that he has a and in case of the orbital defect, we know surgical reconstruction is not possible. But in case of nasal defect, whenever defect is small, surgical reconstruction is always preferred over the prosthetic reconstruction only in cases where defect is very large or there is chances or underlying tissues are not healthy. Like in this case, there is chance of recurrence of the tumor, so we have to go for the prosthetic reconstruction. So for the prosthetic reconstruction, we are using the acrylic for the fabrication of the intermediate prosthesis, while for the fabrication of the final prosthesis, in such cases, we can use either room temperature vulcanizing silicone alone or in combination with acrylic. Like in implanted prosthesis, we make acrylic conformer over which this is attached with the silicone prosthesis. And in case of the complex defect, where the facial defect communicated with the oral cavity, we can use different type of attachment like magnets or other attachments. And with the introduction of the implant, definitely the life of these facial prostheses is increased, as well as aesthetics is further enhanced because the marginal adaptation of the prosthesis is improved as the retention is. So main aim in the rehabilitation of this defect is the restoration of the aesthetics. So as soon as the aesthetics of the patient is improved, that lead to the improvement in the psychology as well as the patient's social circle, or we can say social acceptance of the patient has increased. But whenever we are taking a patient for the prosthetic reconstruction, the clinician must understand the limitation of these material. At the same time, we must explain the limitation of these prostheses to our patient also. Also, because these prostheses require long-term maintenance, as the silicones have very short life of 2 to 3 years in temperate climate, and patient has to remove these prostheses during sleep or water sports, and recurrent cost is involved with these prostheses. Anyway, these are perceived as artificial only. So all these things must be explained to the patient before starting the case. And while examining the patient, we must see the age of the patient. If especially we are planning for the implanted prosthesis, in those cases, we must see whether the growth of the underlying bone is completed or not. We must see the patient ability to maintain the prosthesis, like cognitive, visual, and the mental dexterity of the patient, whether they can maintain the prosthesis and able to maintain the cleanliness of the site where implant was placed. And we must see the geographical accessibility of the patient, whether they will be able to maintain the prosthesis. In terms, these prostheses require repacking or refabrication with short period of time. Then we examine the defect. We must examine thoroughly subjective as well objective examination. Subjective examination, as I said, while examining
अतुल साले दांत बनाया था, वहाँ अतुल दांत बनाए तो वहाँ जो पुरानी वाली सेंट्रल इंसाइजर थी वो दिखाए होते तब ना समझ में आता।
why the defect is created, And if patient give the history of radiation, then we must be extra careful. We must see what type of radiotherapy patient has received, what was the duration, frequency, how much the dose, whether it was more than 60 gray, less than 60 gray. 60 gray, and if patient have a previous prosthesis also, then we must make out why patient want new prosthesis, so that what problem he had with the old prosthesis, that problem that should not be repeated in the new prosthesis. Then similarly, in case of the objective examination, we have to make out the size, shape, location of the defect. And in case we are planning for the implant retained prosthesis, we must do the radiographic examination. Radiographic examination also, just to see the quantity and quality of the available bone, as well as the condition of the underlying soft and the surrounding soft tissue. And we must notice the thickness of the soft tissue also, that may require the modification at the time of the stage 2 surgery. So while we are rehabilitating these patients, as said, first we have to examine the defect. We must take the detailed history, examine both clinically as well as radiographically. Then we have to make a facial molars of the patient, then diagnostic cast. Over the diagnostic cast, we make the wax trial prosthesis. With this wax trial prosthesis, we make with the help of pre-surgical photograph, cast, contralateral anatomy, existing abnormal anatomy. In case the defect is bilateral, or in case of mid-facial defect where the contralateral anatomy is not there, we can use the estimated normal anatomy. So this wax trial prosthesis gives us the estimation where we can use any area for retention. But with the introduction of the digital technique, introduction of the 3D technology, we can take these impressions digitally. So all these steps can be eliminated. So we can see only by recording, scanning the face or taking the impression digitally, how many steps are eliminated in the fabrication of these prostheses. Further, for the taking the impression, we have to make certain line on the patient face to make out where we have to position this is the case of congenitally missing auricle. So where have to place the ear pinna and what should be the position. For that, we have to draw the line, two horizontal line, one from the supraorbital margin, another from the base of the nose, two vertical line, one from the outer canthus of the eye, other from the angle of the mandible. So length of the ear is approximately the distance between two horizontal line. And this line we draw from the angle of the mandible. This indicates the position of the tragus. Tragus is approximately touching this posterior line. In this case, we find some discrepancy. Here is not falling in between these two lines because this is the case of Perry-Robin syndrome. So there is a facial asymmetry was present in this case. In this case, then we make the wax prototype, and this is used to make the radiographic template as well as later on surgical template. So with the advent of the 3D technology, again, when we take the digital impression, digital model, so all these time consuming and messy steps are eliminated. So we have to think about what is the alternative to this. Similarly, in case of the nasal defect, we have to follow all the steps I explained for the the auricular prosthesis, and we have to mark certain landmarks for determining the length of the nose as well as the width of the nose. And in case of the mid-facial defect, again, if the defect is involving the upper lip, then the impression procedure is very messy and inconvenient for the patient. As we have to maintain the patency of the airway, we have to use these plastic tubes, and we can see how much messy and very uncomfortable for the patient while recording these defects. So we think how we can avoid this time-consuming and messy steps for the rehabilitation of mid-facial defect. Similarly, for the orbital defect, although we can see this orbital defect, it looks very simple. This is the orbital prosthesis, but we know while fabricating with conventional method, this is the adhesive retained orbital prosthesis, multiple steps are involved. And in cases where we are planning for the implant retained orbital prosthesis, again, like the auricular prosthesis, a number of steps are required for the fabrication of these prosthesis. So again, we have to think how we can minimize, simplify the procedure and make our patient and clinician life simple. Simple definitely with the introduction of the 3D technology. As we can see in this case, a patient have a unilateral auricle was missing. So with the help of the CT data, this DICOM file was generated. In the DICOM file, what we can do, we can use the contralateral ear to shape the missing part or the missing auricle. This is duplicated, or we can say rather this is mirror image of this ear is placed onto the defect side. Once it is placed, then we have to adjust the position of this ear according to the landmark I had explained in the previous slide. Basics remain the same, whether we are making the prosthesis with conventional method or digital method. But definitely in the DICOM file or in the software, it's convenient to draw the lines or determining the position of the ear as compared to when we are doing it manually. So, as compared to when we are doing it manually, once we determine the position of the ear. So now we have to mark in the software again where to place the implant. As the placing the implant, we know in the auricle region, we have to place the implant 18 to 22 millimeter posterior to the sternoartery meatus, and the distance between two implants should be 15 to 17 millimeter. The same marks we can place in the soft with the help of the software also. So first we have to locate the region where we want to place the implant. Then we see into the pinna which we have duplicated from the contralateral side. We see the relation of these marks in the where they are falling in relation to the ear. We have to place if minor change in the positioning of these we can make out. So before starting the fabrication of this surgical template here, here we have to check the position of these marks into the radiographic images, whether there is sufficient bone is available in relation to the position we had marked. If minor, because in case of auricle prosthesis, we find the sigmoid sinus is lying and mastoid process is full of the air cells. So we must see the implant should not fall or trap in the region of the air cells, and there should not be there should be sufficient bone, 5 to 6 millimeter bone should be present above the sigmoid sinus for the placement of the implant. So again in the software we can do here, we can see the sufficient bone is present where we have placed the marks. So we can superimpose the surgical guide we are planning and see where they are falling in relation to this. Then again, once we had finalized, then we start fabricating this surgical template. Why we had not make the surgical template covering only the auricle? We extend it onto the face of the patient. So at the angle is involved. So this lead to the precise placement of the surgical guide when we are marking the position of the ear on the patient face during the surgical procedure. So this is the final surgical guide we can see. Once we are satisfied with this, we can do either print it with the help of CAD/CAM, or we can print it using the 3D printer. So this is the 3D printed surgical guide we achieved. So these guides are used just to place the marks or mark the position onto the patient face when we are placing the implant in these cases. So CD data is very useful for the diagnosis of the patient in relation to the, because this gives us an exact picture of the bone. In cases where in cases where we cannot, we don't have a full software for the complete planning, what we can do, we can create a mirror image of the contralateral ear. After that, we can print out that. Just here we use the ABS because at that time we don't have a wax printer. So later on, this can be duplicated and we can make out a wax ear. In this, we can place the radio opaque marker. Here we have used the lead foil which comes with the IOPA X-ray. Then we do the CBCT. Later on, in the CBCT, we see, as I said, the position of the implant in relation of bone to the implant position. And then we make the surgical template. So the rehabilitation of these patients require multidisciplinary approach. We require prosthodontic, radiologists, again, either ENT surgeon or maxillofacial surgeon and anaplastomologist. But with the advent of 3D technology, the engineering is intimately related with the rehabilitation of these patients, or become an important part in the rehabilitation of these patients. So previously we used 2D photographs for different facial measurement with the help of vernier caliper or labial or the bevel protector was used. But with the advent of these scanners, this life become very easy. Initially, these scanners was introduced in automobile industry or in aerodynamics. That these scanners which were used in automobile industries are mainly laser based. As these scanners are the laser based, we can see in the picture these are quite bulky scanners, and not due to the laser, but these are designed for use and for the industrial purpose. So these are bulky scanners, but the laser scanners have very good accuracy as compared to the scanners. Although we in the prosthesis, for the fabrication of the facial prosthesis, use the scanner, the optical scanners. Their accuracy is good, but their accuracy is less than the laser scanners. Initially, when laser scanners were introduced, they were composed of mainly 2 cameras and 1 projector. And they were used for the recognition of the face for security purpose on the airport and in armies. And after that, these scanners are used by in the wax museum by Madam Tushar for the fabrication of the wax sculpture. Like we can see in this video, Mr. Obama's face is scanned just to make his statue or his statue in wax. We can see he is happy by inspecting his statue. So this statue is made with the help of 3D printing, stereolithographic printing. The wax is printed with the help of stereolithographic printing. So these facial scanners are used for facial recognition. Capturing the facial emotions can also be captured with these facial scanners. And they are used for planning of the cosmetic surgeries, as well as they are used for the maxillofacial rehabilitation or for the fabrication of facial prosthesis. So with the introduction of the facial scanner, although the modality is comparatively new as compared to other 3D modalities, but it improves the speed and accuracy of the treatment, so that the increase in the speed further revolutionized the total prosthodontic rehabilitation of these such patients. And now, with the further advancement, we can superimpose the CT data with the facial impression that lead to better diagnosis, treatment planning, and the outcome for the rehabilitation of these defects. These scanners can be contact-based or non-contact-based. Although the contact-based scanner is the best surface scanning, but the area they can scan is depend on the dimension of the probe. So mostly, whether for the planning for the cosmetic surgery or prosthodontic rehabilitation, non-contact-based scanners are used. These scanners are based on different principles like laser triangulation, structured light, stereophotography, laser pulse photogrammetry. So the accuracy of these scanners is further depend on which principle the scanner is working. So main advantage of these facial scanners, as I said, they have simplified the life of the clinician as well as the laboratory technician, and again procedure is simplified. And as we are making the model digitally, so we can explain to the patient in a better way, and we can motivate the patient for the rehabilitation or for other purpose. And definitely, as all the steps, cumbersome steps or multiple steps are eliminated or reduced, the patient comfort is increased, and we can make the prosthesis in shorter period of time, and no use of plaster or dental stone. But main disadvantage of the facial scanner which are available till date is difficulty in capturing the deeper tissues. And definitely, initially, we feel difficulty in handling, and these procedures are technique sensitive, and cost of the machine is further disadvantage. As I said, the main disadvantage is we cannot record the depth more than 2 millimeters. And Trias is the only scanner where we can record the depth up to 5 millimeters. And further, when we are doing the scanning, or we are recording the facial image, accuracy becomes less as the distance of the scanner with the face we are scanning increases, and the angulation, there is more number of angulations are there, and surface, if surface is shiny, reflective or transparent objects are difficult to scan with the facial scanners. So further, we see how to the facial, what are the factors which affect our digital impression or digital image, that on which principle this scanner are working. What is the area or the size of the defect, then size of the scanning area, whether what are the surface, whether surface is smooth, amount of surface irregularity, ambient temperature, as well the relative humidity and illumination again. Because in this, with the help of the facial scanner, they record the, we can record the facial color in the real time. So where sometime if illumination is poor, maybe the exact color or the shade of the face may not be recorded in digital impression. So as I said, with the introduction of the CAD/CAM, further the advancement in the 3D technology revolutionized the complete process and rehabilitation of these facial defects using the facial scanner and the along with other 3D techniques involve mainly 3 steps. One is digital impression, then simulation design of the prosthesis, and lastly the rapid manufacturing of the prosthesis. So in the digital impression, while we are taking the digital impression with the scanner, we must ask the patient to sit upright in the chair. And we must explain the patient beforehand. He should not close the eye in between or should not change the facial expression, because and his mouth should be closed manually, as mouth should be closed, because if in between the patient change the facial expression or close the eye or change the position, then entire procedure has to be repeated again. And we must adjust, before starting the scanning, we must adjust the camera position as well as the shutter speed according to the patient face. And scanning should be started from the front of the face, then we start from, we scan the right and left of the face also. Data is saved, and then we do the reconstruct, and data is saved and transferred to the software where there is an optical image of the surface where scanning is formed. So how do we do the scanning? We can see in this with the help of this video. Patient is sitting upright. We can see, we ask the patient to open the eye and his mouth is closed. We are moving the facial scanner around the face. Initially, once we had completed the scanning process, we find the depth of the defect was not completely recorded. So we are repeating the procedure. You can see here now we are repeating the procedure. So once the scanning is completed, once we had captured the defect completely, we have to examine in the clinic the defect thoroughly from all the angles to see the condition of the tissues as well as the amount of undercut. Similarly, here we can rotate the image we got with the digital scanning. We can see it from all the angles, like I'm showing here in the video. We can examine the patient or the defect thoroughly. Once we had achieved use the scanner, we can transfer the data with the help of the software, where we can make the digital model of the patient. In the digital model, the second step is the simulation design of the prosthesis that involve mainly the 4 steps. In the software, again, we have to orient what image we get. We have to do is orientation. It's better to orient it vertically using the facial midline. We can use the glabella, subnasal, pronasal, and the prognathe to orient the patient face in a vertical position. So this position will be followed throughout the planning procedure. And then what the next step is, we have to simulate the missing part size onto the contralateral side, or we can simulate it with the library which is available in the software. Then we have to cut the 3D image of the healthy anatomic structure is separated, and then we mirror it on the defect side. So how we have to do it? We can see that this in video. In case this patient have a orbital defect, we can see once we had completed the scanning. This is the we had completed the scanning. Now, once we had completed the scanning, then on the opposite side we are marking the area according to the defect in the according to the defect side. Defect side, we have to mark the area, then we have to orient the patient face in vertical position. Then we see then we had cut the contralateral anatomy, then we mirror it for the opposite side. This is the midline which we have to follow. Then once we had cut it, we have positioned it. Even after the positioning onto the defect side, now we have to adjust its position. That I will explain in subsequent slides. In case of the orbital defect. The orbital defect, many a time, because we know silicones have a very poor edge strength or the marginal strength, so we prefer to make a spectacle retained prosthesis. So we have to make acrylic conformer just to attach the prosthesis with the specs. So when if we are making a spectacle retained prosthesis with the help of conformer, we are planning. So in that case, what we can do, if we are planning a conformer we can make manually, then we can scan it, or we can make the conformer itself into the software. For that, first we have to scan the defect as shown in the previous video. Then we have to convert that into the STL file. And in the STL file, we can design this conformer. This can be printed. But this is a lengthy procedure. And after the fabrication of the conformer, we have to try it in the patient face. Then we cannot, even though we are not making any change in the conformer while doing the trial, we cannot use the same STL file for the mirroring or the fabrication of the prosthesis on the defect side. We can see while we are transporting the object file into the STL file, there is some distortion in the image. It appears as eye is closed, although the eye is open, so we cannot make a prosthesis. So anyway, for the duplication or the mirroring purpose, we must use the contralateral eye, and we must use the object file only. As here we can see, we have mirror this eye onto this side. Further, if we want to make an implant retained orbital prosthesis, we can do the planning. We can do the planning with the help of the object file we had achieved with the help of the facial scanner, as well as we have to use the CT data. As I said, both can be superimposed. The data obtained from facial scanner and CT scan is superimposed, and we have to visualize it from the different aspects. Then what we can do, we can mirror image. We have mirrored this eye, this contralateral eye onto the defect side. Why we have to mirror it? Now with the help of this, although we know the anatomy is little distorted, but with this give us the idea about where the border of the prosthesis will come. Because in case of the orbital defect, it's very important to place the implant very precisely. Even minor implant, if come into the border area, that may lead to anesthetic effect in the while we are fabricating the prosthetic, or affect the aesthetics. So we can do the planning only with the help of the CT scan in DICOM file. As we can see here, this is with the help of the DICOM file only. And this is just to show or the present. This CBCT, this CT scan was, or patient conformer was made as a short with the conformer. We had placed the mark, then CT was done. Done in the CT, what we find only, we had margin, one along the we have to place in the middle of the supraorbital margin, another in the lateral part. So what we find only in the relation of the distal implant, the bone was present, while in the anterior implant it was falling in the frontal sinus. So these are the advantage when we are using the facial scanner. We can see here in the CT image this red line indicating the image we obtained from the facial scanner, and this is very intimately fitting with the defect obtained by the CT image. So this shows the accuracy of the facial scanner. And above this gray line, this indicates the facial scanner, the acrylic conformer. We had made this patient to make a CT scan with the acrylic conformer with markers. So in case we don't have a facial scanner, we can make the change in the position of these radio opaque marker or the implant position according to we find. But now we do it arbitrarily. We see the how much change has to be made. Accordingly, we do the changes. We cannot repeat the CT scan again. But here we can see the position of the implant in directly superimposed, as we have superimposed the facial scanner, as well as we had used the contralateral image mirror image, so we can very accurately plan the position of the implant, and then we can very well print the we can very well print the surgical guide for the placement of the implant in orbital defect, which can be used especially for marking the position of the implant and placing the implant for the orbital defects. Next is the nasal defect. Nasal defect, similarly, we can, as I had explained for the orbital defect, nasal defect can be scanned. Although the scanning procedure is same, if this patient have a basal cell carcinoma with defect on the base of the nose, although with the partial defect, surgical reconstruction is preferred, but in this case, surgical reconstruction as this patient a basal cell carcinoma was not possible. So this defect was scanned. We can see in the once we scan it, the defect of the depth of the defect was not recorded properly. So procedure was repeated again. Again, we are doing it again to record the depth properly. So once the scanning is completed, we get the image, we can visualize it, inspect it like the orbital defect. This is the file of the patient, obviously file which we get after the scanning. This is the defect in the frontal view, this is the defect in the lateral. Then in this patient, as that we can see the defect is present in the upper part of the nose and the specs will come here. So we had planned for the spectacle retained prosthesis. This is we had designed the conformer in the software. This is the frontal view, lateral view. When this conformer is printed, we have to follow the same procedure as I explained for the orbital defect. And in case of the auricular defect, position for the scanning procedure will be the same as I explained for the orbital as well as for the nasal defect. Here, after for the simulation of the auricle, we have to simulate it in the same way. Mirror image is created, then we have to position it onto the defect side. Then we have to visualize it from all the planes. Once we had position it, we have to visualize it on the plane from the front, from the back. We have to see the distance from the skull as compared with the contralateral side. We have to see from the top as well as from the base. Base whether what, and we have to see the angulation also. Also whether the when we have create a mirror image and we position it on the defect side, we must see whether this positioning is correct or not. Most of the time we have to do the corrections. We can do the correction into the as the ear is not straight. It is an angle approximately 20 degree, or its angulation is parallel to the bridge of the nose. Then we have to make further corrections. Further corrections according to the post when we examine in the posterior or superior or the inferior view, we can correct the inclination in the position of the prosthesis. Once we are satisfied with the position of the prosthesis and we have made all the rectification is any rectification required in the design, and we have to mark the margin of the prosthesis, make it feather race. Once we complete all these steps, then we can print the prosthesis in resin ABS, or we can print it in wax. Or if we want to make a mold for the final packing of the prosthesis, we can make a negative mold. In that case, this ear image, which we have done the wax carving, is transferred to the negative volume or in the software for the 3D printing of the acrylic mold, or 3-piece mold for the fabrication of the ear prosthesis, while for the nasal and the orbital prosthesis, 2-piece mold can serve the purpose. For the auricular prosthesis, if we are planning whether it's auricular or the midfacial orbital, if we are making an implant retained prosthesis, in that case, after the stage 2 surgery, so for the fabrication of the facial prosthesis, we can examine the defect. After the stage 2 surgery, we can rescan the position of the implant for the fabrication of this either bar or fabrication of the substructure, or if we are planning to use the stud attachment, we can plan the stud attachment place the stud attachment, scan it, and we can plan the prosthesis in the same way as I explained. But in case we are planning for the bar, we have to make it in the same way as we are making it for the overdenture. We have to scan this, carry it into the software. Same software, Exocad, can be used for the milling of the bar. For the designing of the bar, then we can mill it using the CAD-CAM, then we try it on the patient face. After that, this conformer can be made with conventional method, or we can make in the software. If we are making the software, it's better to rescan the defect. Then the last step in the fabrication of maxillofacial prosthesis is the final fabrication of the prosthesis, or rather we can say flasking and final packing of the prosthesis. So in the case we are using the digital method for the fabrication of the prosthesis, we can do direct packing in the mold. If we have 3D mold, we have to make in acrylic resin, or if we have printed it in either in ABS or the wax, we can use the conventional method for the packing. Advantage of the indirect packing over the direct packing is that in this case, we can try the final prosthesis on the patient face. If minor alteration into the margin or weave is required, those can be done at this stage also. Then we have to follow the conventional method for the packing. So this picture we have taken from article in JPD. So these are the printed pictures. Then we have to do the flasking. For the flasking, as said, we can further define the position of the margins. So once we have rectified the margin, then we have to seal the prosthesis onto the, this is the model with the conventional method. We are sealing the margin, then we have to make the margin feather as here we can see, then we start the flasking. First, like in the complete denture cases, we have to make the first pore, and here we have inserted this prosthesis in the flask. We can see it's better to use IV. For this pore, we can use POP very well. And this must be flushed with the border of the flask. You can see this. We are doing the flasking. Then we have to prepare the second mold. Once it dry, set completely, we are using here we can use the cold seal. After the cold seal, we have to pour the second pore for the ear prosthesis. That is the area behind the antalix portion of or behind the elevated part of the pinna we can see. So this distance should be approximately 9 to 10 millimeter, or rather 1 centimeter. We can say we are using the lap putty. We have to mark it. Then we use the white color dental stone or the orthocal. This is pour in this area. We can little tap it. And while we are placing this lap putty for this purpose, we must be very careful. It should be divergent, not convergent. It should be narrow from the lower. Then we have to trim this flash with the BP blade. We are trimming it to make it parallel to it. So there should be no undercut. Here I'm showing there is no undercut. Once this is finalized, again we can use either we have to apply the cold seal. This is the channel. We are using the modeling vest to make the channel. So while we are doing the packing in the silicone, this is the escape hole for the flow of the extra material. We are applying the cold seal. Now we will do the final pour or the third pour. So over the pinna, to avoid the entrapment of the air, it's better to paint it with the brush. Then fill it with either with the POP, or we can use the dental stone. This is filled completely. Then we have to close it and place it into the clamp. Once it is set, we do the dewaxing. Here we are doing the dewaxing, and we must remove the, we are showing how we are doing the dewaxing. And this we can see we got the 3-piece mold. This is the third piece, first cast, and this is the second piece. This is the 3-piece flasking we have done for this patient. This is the conventional method for the flasking of this patient, or with the help of 3D model. This picture again taken from this article. This is the acrylic mold we have printed. The author has printed with the help of the 3D printer. So packing can be done. Here we can do the packing with the injection molding technique in the using the acrylic mold. So this is how we can make the prosthesis using the facial scanner or the digital methods. So as I had explained, with the advent of the facial scanner and the 3D technology using the CT data, definitely the fabrication of the prosthesis becomes simpler and cumbersome, or the messy steps are eliminated, and it leads to the save in the time, and the procedure is more precise. We can fabricate the prosthesis more precisely, and because the accuracy of these scanners and these methods are good, so it further give better aesthetic results. So we must understand their use, their limitations, so that we can imbibe them, the new technology, and use them in our daily practice. But we must acknowledge the limitations of these methods, as well as the material we are using for the fabrication of these prostheses. And we must explain everything to the patient in detail before starting the procedure, so that later on patient will not feel they are cheated, or they will not explain completely, because anyway face is very important to us. It gives us identity. Thank you. Session is open for the question answer session. If any question, please ask.
Thank you, ma'am. Very elaborately defined video of making a maxillofacial prosthesis. I hope our participants got benefited from this. If anybody has any questions to ask, you may either put it on the chat box, or you may unmute yourself and then ask, ma'am. Okay, so we have one question, ma'am, from the party. What is the difference between STL and object?
STL file, actually, when we do the scanning procedure in the patient face, we got the object file. Then in the software, we have to convert into the STL file. In the STL file, we further processing or the fabrication of the prosthesis for the, even to transfer the data from, suppose we had scan a file and we store the data in one computer, we want to transfer it either to the 3D printer or the CAD/CAM machine, we want a STL file. So scan data is the object file.
Okay. So next question we have, ma'am. Even if the prosthesis is designed by the software, how can silicone be milled or printed? Can you please explain?
Yeah, Dr. Richa, actually, till now, printable or the milled silicones are not available, which can be milled. Definitely, research will be going on, but it's not available till date.
Yes, but for the mold, we can definitely design.
Yeah. As I show in the picture, we can make the mold or print the processes, which can be processed using conventional method.
Right. Till the time we have more advanced 3D printing materials which can be used.
Yeah. We have to, last step is conventional only.
Yes. So another question is, what are the different materials which are used for facial prosthesis?
Yeah, for the fabrication of the facial prosthesis, although in the ancient time, as I said, we use wood, metal, but now we are mainly using the acrylic and silicones. Acrylic we mainly use for the fabrication of the interim prosthesis, especially in case of the mid-facial defect, where we don't want our patient to live with the open defect. No open defect and patient is ridiculed by peers, or there is chances of dust collection and the infection in that area. We don't want further infection. So in those cases, we have to make our interim prosthesis for the facial defect. Then interim prosthesis we make in spectacle retained acrylic only. And final prosthesis either in room temperature vulcanizing silicone or HTV heat cure vulcanizing silicone, but RTV is preferred over the heat temperature vulcanizing silicone, because RTV have a better translucency as compared to the HTV, and their edge strength is also better. better. So for the fabrication of the small prosthesis, and for the HTV, again different type of the flask and armamentarium is required for the final processing of the prosthesis. So RTV are preferred over HTV.
Okay. So another question is on shade matching, ma'am. So the participant wants to know whether the shade matching be ensured when the final prosthesis is done conventionally, although software part of shade matching would be easy.
Definitely, there is no definitive software for according to the human skin. Although some instruments are available which give us a rough idea about the composition of the skin. But anyway, final shade matching we do manually, and we do manually, and while doing the shade matching, we must see about the surrounding light. Should be it's better to do in the daylight, which has a complete spectrum, we have to say. And another important point, the final shade matching come with time. You are doing the first time, maybe you are not that much familiar with the pigment, how much pigment we have to use, because we have to add the pigment in very traces, very small amount, and we should not use too much amount of pigment than our prosthesis once it come out, although we find shade is match. But final prosthesis will give a dead appearance, or it will look too opaque from the front.
And I think spectrophotometers are used, handheld spectrophotometers are also used to match while you mix.
Yeah, I said they are available, but they are not very accurate. Finally, we have to confirm with our personal perception.
Our experience, yes, our experience, yes. Right. Okay, so one more question is, can you, ma'am, highlight more on printable materials and how we can manage hollowness in full workflow if at all needed?
Printable material, till now we see, as I showed for the facial prosthesis, ABS is available, printable wax are there, and printable acrylic are also there. But now the printable biocompatible acrylics are available, but they are of different type. One is which are not biocompatible, like which are the acrylic used to form the mold, and other is the material which has limited biocompatibility, the one which is used for the fabrication of the surgical guide, and other is completely biocompatible acrylic, which are used for the fabrication of complete denture prosthesis. So acrylics are available, but till now what I think for the facial prosthesis purpose, these three materials are available in printable for the printing.
Then I think as per the printer which you have, there are definite materials which are compatible with printer. So if you visit the sites of these printers, like if you visit Formlabs website, you can see which materials are compatible with Formlabs and can be used.
Yeah. Till now, most of the printers are the closed system only, like Dr. Richard said. We cannot use all the materials in each printer. And some printer are now open system has come up, but rather
still, ma'am, this way to go in 3D printing, right?
Yeah.
I think with this, we thank you once again, ma'am, for this wonderful presentation. And thank you for being a part of this session. Thank you. And thank you, participants. We'll join again tomorrow, 5 p.m.
Thank you.
Thank you, ma'am.